Okay, are there any questions, guys? Do you need to ask me any questions? I'm starting UWORLD. I don't know why my internet is lagging today. Okay, let me. All right. All right. Okay. All right. I'm sharing my screen. I hope you guys are doing good. So let us start. All right. Okay. So this is the first question of today. Eagle syndrome. All right. A 66-year-old man undergoing a procedure due to Eagle syndrome, a condition frequently caused by a mishappen or elongated style-wide process. You know, this is something new. This is Eagle syndrome. This is something they discovered last year, and then they decided to put that in UWorld. So this is how, when I say that please do UWorld, do not do any other question bank, because you know they update the information daily. All right. During the procedure, the styloid process is trimmed surgically. However, the left glossopharyngeal nerve is accidentally transected. Which of the following is most likely to be seen in the result of the patient's nerve injury? What do you think is wrong? Guys, what do you think is wrong?
So we're talking about the sensation that the left glossopharyngeal nerve give. Yes, so it's affected. It means something is wrong. I would say D.
Okay. So anybody else?
Yes, C and 11.
I'd say C.
For this kind of
D.
question,
Yes,
I'll say C.
glossopharyngeal is with the D, loss of general sensations at the tonsillar area.
I think it's better in these questions to read all the answers and
Yes, we
Okay.
can exclude one by one.
include
Why
exactly.
deviation of the protruded tongue towards the left? What does this do?
Hypoglossal nerve.
Exactly, that's hypoglossal. Then we have hoarseness due to left vocal cord dysfunction. What is that?
That is the
Laryngeal.
different laryngeal.
Laryngeal.
Very good. That's a laryngeal nerve. Then we have impaired taste sensation from the anterior two-third of the tongue.
The facial nerve.
Mandibular branch.
All right. Why isn't it reduced salivary secretion from the submandibular gland?
It's also the facial nerve function.
Sjögren's syndrome.
So we all agree that it might be D. And yes, it's right. So the glossopharyngeal nerve, we know it originates in the medulla. And the important functions that I want you to remember are these. The general sensory, all right. It kind of innervates the tympanic membrane inner surface. What I want you to remember, tonsillar region over here, it's very high yield for you to remember that. And also know that the glossopharyngeal nerve lesions result in the loss of general sensation in the upper pharynx. And what I want you to remember over here is the loss of the gag reflex. All right. So whenever they ask you what is gag reflex mediated by, you know that it's mediated by glossopharyngeal nerve. So if you have any injury to that, you also have loss of the gag reflex. All right. We talked about how protrusion of the tongue towards the left is mediated by the hypoglossal nerve. We talked about how hoarseness of the larynx is associated with the laryngeal nerve. Taste sensation is by the facial nerve. We also talked about how the salivary secretion from the submandibular gland is also again innervated by the facial nerve. Again, root memorization. You unfortunately you have to memorize the nerves and what are they innervating, as I said in the musculoskeletal module as well. So lesions of the glossopharyngeal, we talked about the gag reflex. It's very high yield for you to remember gag reflex, tonsils, is very important, and this loss of taste sensation on the posterior third of the tongue, that is very high yield for you to remember. All right, three things: high yield, loss of taste sensation on the posterior third of the tongue, tonsils, loss of gag reflex. All right, okay. We come to the next question. All right, what is this? What is this?
The circle of Willis.
Circle of Willis.
Exactly, that is the circle of the Willis. All right, okay. What is D? What is D? What is this?
Posterior
Communicating.
Communicating.
Communicating artery.
Very good. That's the posterior communicating artery. What is this?
Anterior.
Anterior
Anterior
communicating.
Anterior.
communicating.
Okay, what is this?
Posterior cerebral artery.
That is the
PCA.
PCA.
Very good. What is E?
P is
Internal carotid.
and MCA. Media. Media
Posterior.
cerebral artery.
Posterior communicating.
That's the communication.
Cerebral artery.
Communication.
Communication.
All right. What is C?
Middle
C
cerebral
is-
artery. MCA
All
branches.
right.
CMCA branches.
So we know
C.
that this is the posterior communicating artery. You know, this is the anterior choroidal artery. They have not marked it. All right. We also have an ophthalmic artery over here. So this is the ophthalmic artery over here. We know that, right? Okay. What is this? We talked about this. What is this?
The branch of the media communication artery.
All right.
Middle cerebral artery. Branches of middle cerebral artery. Not don't know the specific branch.
Exactly. Okay. So we talked about that, and then we know the what are these small arteries?
The lacuna.
Okay. What do you mean? What is this?
Superior cerebellar artery.
superior
Exactly.
cerebral.
This is
Cerebral
the
artery.
cerebellar artery. This is the basilar artery. We know that these are the
Yes.
pontine arteries,
Yes.
right? Okay, we know that these are the pontine arteries. Then we have this is the anterior inferior cerebellar artery. All right, we know that, and you know there is also one artery that kind of comes over here that's known as the anterior spinal artery. We know that this is
Yeah.
the vertebral artery.
Mhm.
All right, and what is this?
Pica?
Yeah, posterior inferior cerebellar. All right. Okay. So we're kind of familiar with the circle of Willis. These arteries are known as the anteromedial central arteries. Not high yield for you to remember, but these are known as the anteromedial central arteries. And we know that this is the anterior communicating artery. All right. We know this is the anterior cerebral artery. All right. We know that this is the middle cerebral artery. All right. And what is this?
Internal carotid.
Internal carotid.
Exactly, that's the internal carotid. So we kind of have an appreciation of what the circle of Willis looks like. Now let's go and see what they are asking. All right, so they're saying that the neurological examination shows that he is awake, alert, and oriented. All right, visual fields are normal. The position of the right eye is down and out with ipsilateral ptosis. What artery affects this?
This is okay.
Ocular.
Third cranial nerve is
Oculomotor.
affected. Third cranial nerve, oculomotor.
Yeah, oculomotor.
Okay. Now let's see what is happening. Right pupil is dilated and non-reactive to both light and accommodation. Left eye examination is normal based on the patient's neurological deficit. CT angiography of the head is most likely to reveal an aneurysm of which of the following locations. All right. So they're saying that there's this 55-year-old right-handed man comes to the ED due to recent onset of severe throbbing, right-sided headache, and double vision. What is he having? What is he having?
It's a stroke.
Yeah, it's a stroke. Very good. So what do you think is going to happen? Which artery is going to get affected? They ask us about that there is ipsilateral ptosis and the right eye is down. All right. So what do you think is going to happen?
Right-sided oculomotor nerve is affecting the PCOM. right-sided PCOM.
All right. We know in PCOM we have
D.
they have a down and out pupil presentation in PCOM.
That would
All
be
right.
Yes.
So
D.
what is the PCOM over here?
D.
D.
Right-sided. D.
right side.
No,
Episilateral.
D. D
D.
for dog.
D. Yes.
Exactly. All right.
Oklahoma.
Okay. All right. Now let's see. We discussed about that. All right. So the answer is D. And yeah, so these are the saccular berry aneurysms that we talked about. If I kind of just enlarge this a little bit, we talked about that this is a circle of the Willis. We know that this is the posterior communicating artery. We talked about this circle of Willis a few minutes ago. So we know that the patient has right oculomotor nerve palsy secondary to a compressive aneurysm, and we know that PCOM causes a down and out pupil. So it's very high yield for you to remember. Also know that the saccular aneurysms are associated with this type of association as well. What else I want you to remember over here is these lines. These are very high yield for you to remember, these lines. Okay. Aneurysmal compression of cranial nerve 3 produces mydriasis. What do you mean by mydriasis?
Dilatation of the pupil.
Exactly. That's
Dilation.
Meiosis is the constriction of the pupil, all right, with diplopia, ptosis, and down and out. So whenever you see a down and out, usually PCOM gets affected, all right, and PCOMs are highly associated with saccular berry aneurysms. All right, that is what I want you to remember. Okay, if you kind of go through this, they literally tell us the same thing, that they produce mydriasis, diplopia, ptosis, down and out deviation. Very high yield for you to remember. Posterior communicating artery aneurysms are most commonly associated with saccular berry aneurysms as well. All right, next question. Okay. All right, so she says that what's happening, physical examination shows fullness of the preauricular space on the right side. All right, MRI on the region identifies 2 to 2 centimeter mass in the right parotid. Okay, I know this answer, what's going to happen. What do you think is the answer?
B.
It's a facial nerve.
Facial. B.
B.
It's
B.
What's
Facial.
happening is that in parotid gland surgeries, most commonly facial nerve injury happens. All right, because facial nerve kind of loops around the parotid gland. So what happens when you do a parotidectomy? What happens? There is commonly a risk of facial nerve injury. All right, and that is why you have facial droop as well. Why isn't it facial numbness?
Facial palsy.
This is
This is motor.
numbness. This is the trigeminal, the ophthalmic.
Yes, trigeminal nerve.
Sensory is via fifth nerve. Trigeminal.
Yeah.
Exactly. So see, you can see that over. You can see that over here, cranial nerve 7. What you need to memorize is that the parotid gland is, kind of has facial nerve associated with it. So if you do a parotidectomy, what happens is the facial nerve gets injured and you may have facial droop as well. Most common complication of a parotidectomy is usually facial nerve injury. All right. Again, root memorization. There's nothing which you need to kind of go through that. All right. I want you to know, what is Horner syndrome? What do you mean by Horner syndrome? What happens in Horner syndrome?
No sweating.
Ptosis, meiosis, and hydrosis.
Meiosis and anhydrosis.
It's
There
because
is
of sympathetic loss. It's because
Exactly.
of sympathetic trunk loss and the ptosis, meiosis, and anhydrosis. It's the triad of the.
exactly. So there is this mnemonic in first aid, Pam is horny, and you must see that P for ptosis, A for anhydrosis, M for meiosis, and horny, Horner. All right. Okay. So that's a beautiful mnemonic if you kind of want to go through that. And that's what happens in Horner syndrome. In what conditions do you usually see Horner syndrome?
Fanconi syndrome.
Bell's palsy.
What else? Is somebody, have somebody read the respiratory topic? There is this also some cancer. Exactly.
Pancreas tumor.
Pancreas tumors of the lungs are associated with Horner syndrome as well. All right. Where do you have bitemporal hemianopsia? What is that?
When there is
Plasma
optic
defect.
chiasma compression, optic chiasma compression because of
Optical
some
rod.
pituitary tumors like craniopharyngiomas can cause the compression of optic chiasma that leads to bitemporal hemianopia.
So bitemporal hemianopsia means loss of peripheral vision on both of the sides of the eye. You cannot see who is going to hit you. You cannot see the peripheral vision that is lost. All right, it usually occurs when you have a pituitary gland tumor or anything that is disturbing the optic chiasm. In most cases, it is the pituitary tumor that's causing bitemporal hemianopsia. So in patients who are having bitemporal hemianopsia, urgent CT MRI of the head is warranted. All right, because of the risk of a tumor. The other thing, what do you mean by strabismus? What is strabismus?
Squinted, being squinted.
Eyes, splintered eyes.
Exactly, squint. So strabismus means squint. Very good. All right. That's also the improper alignment of the eyes. All right. It can result from disorders of the extraocular muscles. We are going to discuss it in the eye module in the future. But okay. So that's their next question. All right. So what is happening? The patient has a history of hypertension type 2, exercises regularly, does not use tobacco, alcohol, a lesion affecting which of the following structures? Okay, visual symptoms. So he's having some visual symptoms. 53-year-old man, double vision. The patient lives in two-story house, all right, difficulty walking because he sees duplicates of every steps. All right, he does not have significant problems walking upstairs. Patient is frustrated. He has trouble reading certain things, such as the morning newspaper. All right, what do you think is happening?
So there is a defect in the superior oblique muscles because it's only because this muscle is responsible for reading and like the downstairs. So that's why it's a superior oblique muscle which is innervated by the trochlear nerve.
Mm-hmm. Yeah. All right. Somebody else?
I guess she's right.
Trachea nerve palsy.
I think the superior oblique turns the eye down and in, so it helps, like she said, with reading and going down the stairs.
All right. Okay. So we all agree on trochlear nerve. Yes, it was a trochlear nerve palsy. We know that trochlear nerve is a cranial nerve 4. It supplies the, who remembers the mnemonic SO4 LR6?
Yeah.
Who, yeah,
So
superior oblique, cranial nerve 4, and LR is lateral rectus, cranial nerve 6. All right. Okay. What is the cranial nerve 6 called?
Abducens.
Very good.
Abducens.
All right. So patients who are having superior oblique muscle weakness because of a cranial nerve palsy, what do you see? You see kind of this image. So what's happening? That there's hypertropia and extorsion. You can see that the eyeball is kind of going towards outwards and upwards. All right. So outwards and upwards occur. Why? Because of the cranial nerve 4 palsy that is kind of innervating the superior oblique muscle. That's really important. We talked about abducens nerves. It innervates the lateral rectus and it's responsible for the abduction of the eye. So when there's palsy of this nerve, it's going to cause horizontal diplopia and inward deviation. All right, we know about that. What is medial longitudinal fasciculus? What do you mean by that? What do you mean by intranuclear ophthalmoplegia? What's that?
I think it helps with lateral gaze.
Very good. What does the oculomotor nerve do?
It moves the eye up and like medial, and it elevates the eyelid and it constricts the pupil.
Mm-hmm. What else?
It's responsible for the or no, sorry.
Eye movement of the
Okay.
people.
What does the optic nerve do?
Vision.
Okay, yeah. So we know that the trochlear nerve, it innervates the superior oblique muscle, causes the eye to internally rotate and depress while adducted. So we talked about that. Patient may compensate. What is important in high yield for you to remember? What are the eye muscles? What are they getting innervated by? What is going to happen if there is a palsy of that nerve? How will the eye pupil present? All right, that's what you need to memorize from over here, and you can get most of these questions right. Do not dive into the like dynamics of how it's going to happen, or just it's not important. What's important is how it will present and what are the muscles the nerves are innervating. All right, next question. Okay, so physical examination, mild periorbital ecchymosis in ophthalmos. What do you mean by that? What do you mean by in ophthalmos?
Eyeball will move inside.
Wow, thank you for telling. I did not even know that. So thank you. Okay. I don't know if it's right. I mean, you guys know because I don't know about this. All right. Okay. Visual acuity and left eye examination are normal. CT scan of the face reveals an orbital floor fracture. Okay. Which of the following additional findings is most likely to be seen in the patient? So 16-year-old boy comes to the ED after an eye injury. All right. Okay. So the baseball was hit in the right eye, and the patient has diplopia, periorbital ecchymosis. What are orbital fractures associated with?
It is associated
Maxillary
with
nerve.
inferior orbital nerve because it passes through the foramina, or that is over the orbital floor, and the inferior orbital nerve supplies the upper lip.
Yeah.
So it will be the E, reduced sensations.
All right. Why would it be absent right corneal reflex?
Because it is mediated by the V1. I guess.
V1, yes.
Okay. What about inability to puff out right cheek?
Facial.
Buccinator, that is the muscle, facial, buccinator muscle that is
Buccinator
supplied
muscle.
by the facial nerve.
Oh, very good. Okay. What about impaired olfaction?
1 CN1.
Olfactory is
Olfactory nerve.
Olfactory.
Optic nerve.
NF1.
V1.
Yeah, V1.
Okay. Now let's see if we were right. Yes, we were right about that. So we know that the ophthalmic zone, it's also the maxillary mandibular, it's kind of the division of the trigeminal nerve. And how this is the mandibular branch, that's the maxillary branch. So we know about that. All right. So whenever you have orbital floor fractures, again, high yield, this muscle is very high yield for you to remember. All right. So in orbital floor fractures, there is an entrapped inferior rectus, and that is why you have diplopia on upward gaze. All right. This is a very high yield thing. Write it down, mark it down, very high yield. They are going to ask you that in question. What muscle gets affected in orbital floor fractures? That's inferior rectus. And that is why we have diplopia on upward gaze. All right. In addition to that, we know that the infraorbital nerve, that's the like a continuation of the maxillary nerve, and it runs through that, and it supplies the upper cheek, lip, and gingiva. All right, we talked about why isn't it the corneal reflex, because it involves the trigeminal nerve. All right, it does not involve the continuation of the maxillary nerve. All right, then we have hematomas over the mastoid process, battle sign. They are a sign of basilar skull fractures. They are not a sign of the orbital skull fractures. We have impaired olfaction. We know that olfactory nerves supply the olfaction. All right, then we have facial nerve. It controls the motor function of the face, and it travels through the temporal bone. So whenever you have temporal bone fractures, for example, a lot of bike accidents, whenever people drive without helmets and they get into accidents, people who ride bikes, they have the most common cause of fracture in people who ride bikes are temporal bone fractures, and that is why the facial nerve gets injured. All right. So we talked about that. We know about that. It's a root memorization thing. Again, memorize this. Unfortunately, no other thing which can help you get past it. All right, next question. On neurological examination, he is unable to adduct his left eye, and stimulation of the left eye cornea does not elicit a corneal reflex. A lesion involving which of the following anatomical structures is most likely responsible for the patient's symptoms? We have a 62-year-old man, double vision. All right, we talked about this. What do you think is happening?
Superior or no?
What is the answer?
F. Superior orbital fissure.
Yeah.
Again, very high yield for you to remember this, where they are passing. All right, we talked about this is superior orbital fissure, what type of nerves are coming through that, and this is the inferior orbital fissure. What are the nerves? Infraorbital nerve, artery, zygomatic nerve, optic canal. Again, I know you guys hate it, you don't want to memorize this, but unfortunately no other way. You have to memorize this. There is no other way you can remember it. All right. Okay. So the oculomotor nerve, ophthalmic nerve, trochlear nerve, and abducens nerve enter the orbit via the superior orbital fissure. Again, kind of rude memorization. Nothing that needs to be explained here. All right. Next question. On examination, lower extremity strength is 5.5 bilaterally. The right leg has a large area of numbness over the upper lateral thigh. Straight leg raise is negative. Reflexors are symmetrical and intact. Compression of which of the following nerves is most likely cause of the patient's presentation? All right. So we have a 56-year-old man. He comes with evaluation for right leg pain and numbness. Pain started 2 days ago during an 8-hour. All right. What is happening? What is this?
Myalgia parasthetica.
Yes, the lateral femoral cutaneous nerve is affected on the
yes.
I talked about how lateral femoral cutaneous affects obese people or people who wear tight garments. It gets affected, and you have loss of sensation in the lateral part of the thigh. All right. We talked about that. Again, that's myalgia parasthetica. Again, it also presents with patients with diabetes mellitus. Usually diabetes mellitus, why? Because obesity. So obesity is kind of a risk factor or a segue to diabetes mellitus. All right, next question. All right. The external auditory canal and tympanic membrane are normal. A disorder affecting pterygoid muscle contractility is suspected. Involvement of which of the following nerves is most likely contributing to the patient's ear symptoms? So we have a 26-year-old woman. She comes in due to pain and muffled hearing in the left ear, along with a sensation of jaw clicking when she's chewing food. Patient has had episodic headaches and left-sided facial pain, worse when moving the jaw. What is grinding of the teeth called?
Bruxism.
Exactly. Grinding of the teeth is called bruxism. And a lot of patients who grind their teeth while they're sleeping, they usually have temporomandibular joint disorders, and that is why it's advised that you do not, kind of grind your teeth. She reports passive pain. What's happening?
Mandibular nerve damaged, pterygoid muscle is getting damaged. So
All right. Again, I told you that it's so see how they will throw it in as a distractor for most of the patients. So TMJ is a common distractor for patients with giant temporal arteritis. All right. So it's a common distractor. How will you differentiate it? Again, TMJ disorders have usually tenderness of the jaw. They have also TMJ tenderness is also present over there. They will give you a history of bruxism. Pain is worsened when she moves the jaw. Again, common distractors, you can eliminate out it like that. All right. So we know that TMJ is kind of innervated by the mandibular nerve. And mandibular nerve is a continuation of a trigeminal nerve. Trigeminal nerve divides into 3 parts: mandibular, maxillary, and what's the third?
Ophthalmic.
Ophthalmic. Very good. All right. So we know that it was a TMJ disorder. Temporomandibular joint kind of goes through that. And mandibular nerve. So even if you kind of use logic, it can also kind of give you the answer of that. All right. So again, root memorization, nothing to be explained over here. Next question. Okay. So what is happening? Right lower extremity examination shows weakness in dorsiflexion, plantar flexion, and knee flexion. Hip flexion and knee extension are normal. Sensation to light touch is decreased on the dorsum of the right foot, all right? And posterior lateral aspect of the right calf. Ankle reflex is absent on the right. Which of the following is causing the patient's finding? So we have a 68-year-old woman she's evaluated for right lower extremity weakness while hospitalized. The patient was admitted after, all right, so she had like a fracture and she underwent total hip arthroplasty. Her operative course was uncomplicated. Since the surgery, she'd had difficulty with physical therapy. She has numbness, type 2. What's happening?
Sciatic nerve injury.
Why do you
D,
think
L5 radiculopathy.
Sciatic nerve injury.
Yeah, it's sciatic as there is a plantar, like a weakness in dorsiflexion and plantar flexion.
exactly? Striatic nerve. So why isn't it L5 radiculopathy? L5 radiculopathy usually occurs in patients who are having disc herniation. She is not presenting with disc herniation signs. Is she presenting with disc herniation? You also have loss of, kind of like autonomic nervous system within, for example, loss of bladder control. Also, urination symptoms will be present with disc herniation. They're not present over here. So yeah. All right, lacunar strokes. Where do you see lacunar strokes? In what patients?
Hypertensive diabetes.
Hypertensive. Yeah.
Very good. So you see lacunar strokes in patients who are having hypertension, diabetes mellitus, very important risk factors for lacunar strokes. Lacunar strokes, they affect the face, arm, and leg. Again, there are two types of strokes, motor strokes and sensory strokes. What does motor stroke affect? What part of the brain? What's a pure motor stroke?
Sorry,
What's
Movement.
the question?
What is a pure motor stroke? What part of the brain will it affect?
Left.
Ooh, that is left, but what?
The motor.
Primary motor
The primary motor cortex.
Yes.
yeah. What part will it involve? The posterior limb of the internal capsule or thalamus?
Posterior limb of the internal capsule.
Thalamus.
Who else? Guys, come on. Anyone else?
Is that presental gyrus?
So pure motor strokes cause, in the posterior limb of the internal capsule, all right, whereas pure sensory strokes usually affect the thalamus. So that's very, again, high yield for you to remember. Okay. Then we come to down. We know that sciatic neuropathy, again, it's a common complication of hip fractures. We know that when there is injury to the sciatic nerve in the pelvis, it causes neurological deficits across the sciatic nerve, knee flexion, common peroneal nerve. So we know about that, what's happening. The ankle reflex is also lost. Again, root memorization, nothing to kind of grasp on. Again, on examination, he leans to his right side when walking. When the patient is asked to stand on his right, again, hip tilts downwards. What's happening? We discuss this a lot of times.
Trendelenburg sign.
Trendelenburg.
All right. So we all agree with superior gluteal? That's the Trendelenburg sign. We know superior gluteal, it innervates the gluteus medius and minimus, and whereas the inferior gluteal nerve, it innervates the gluteus maximus. We know that as well. All right, that's known as the Trendelenburg sign. So they're going to walk like that. All right. Okay. Then we come to the next question, question number 11. When the patient is asked to stare straight ahead, the right eye is directed inferiorly and laterally. Okay. What muscle?
What muscle doesn't injure?
Yeah.
Mhm.
It's lateral rectus.
Addison's nerve? Superior rectus?
C. Lateral rectus.
No, it's oculomotors injured, and the lateral rectus doesn't injure.
So we all agree with the
Internal
lateral.
function.
We all agree with the lateral rectus. Yes. Again, we can see over here that oculomotor nerve, it innervates superior rectus, medial, inferior oblique. And these are the functions that it does: abduction, depression. What I want you to remember is the lesion findings from here. And this what I want you to remember. All right. So eye is in oculomotor nerve palsies, eye is deviated downward and laterally. You have diplopia, you have ptosis. In trochlear nerve injury, what's happening? Whose mic is open? All right. Please close your mic. Okay, so it's the eye is deviated upward, vertical and torsional diplopia, and abducens nerve palsy. You see the eye is deviated medially. Again, I told you that the innervations are really important in the eye. What muscles they're supplying? What are the lesion findings? They are very high yield for you to remember. Again, oculomotor nerve palsy. Again, why are they happening? Most of the palsies are happening of the because of the aneurysms, and those aneurysms enlarge and they kind of compress on those nerves, and that is why palsies happen. All right. Okay. Next question. So the patient is concerned because he is right-handed and cannot perform his duties as an electrician. On neurological examination, there is diminished strength on extension of the right wrist with an absent triceps reflex. Okay. Injury to which of the following nerves is most likely there? Okay. So there's this patient who came because of right upper extremity weakness. What do you think is the answer?
Radial
Nerve.
nerve,
Radial
Radial
nerve.
nerve.
radial, extensor, triceps absent.
Exactly. We have talked about this a lot of times that extensor muscles, flexor muscles are very important for you to remember. Wrist drop also occurs when there's loss of the extensor muscles. There's also an absent triceps reflex. Very high yield for you to remember. Nerves we have gone through like thousands of times as of now. So I will not go through the nerves again and again and again. We have gone through this thousands of times. Now you need to be very familiar with what's happening over here. All right. Then we have a next question. Physical examination shows tenderness to palpation to the right chest wall. Nerve block procedure is planned to control the pain by injecting a local anesthetic agent in the vicinity of the involved neural structure. So what's happening? 64-year-old woman with history of lung cancer. She came because of persistent chest pain, squamous cell carcinoma, invaded the lower and fourth and fifth ribs. She has had severe right-sided chest pain exacerbated by movement or cough. The patient was given an opioid analgesic but could not take them at the prescribed dose due to excessive sedation. What is happening? What's happening?
It's
I think it's the phrenic nerve.
Where are you going to put it?
intercostal.
I think phrenic.
Intercostal.
The intercostal nerve.
I think the
Intercostal.
thoracic separator.
Intercostal.
Intercostal nerve.
Why not inferior cervical ganglion?
Because it's really deep.
Okay, so we all agree with the intercostal. You sure?
Yes.
Yes.
Yeah, very good. Okay, so it's intercostal nerve. We know that the sensation to the parietal pleura, chest wall, skin of the chest, it's supplied with the intercostal. So intercostal nerve blocks are usually given to people who have a lot of pain because of coughing, and they have chest pain because of that. So this is if I kind of do this, you can see that these are the intercostal nerve and arteries. This is the syringe that's getting inserted. This is the right lung. These are the intercostal muscles. These are the nerves, and these are the superficial nerves, and you can kind of numb them so that they don't feel the pain. All right. Okay, where is the phrenic nerve? What does the phrenic nerve do?
supplies the
It
diaphragm.
supplies the
diaphragm.
diaphragm.
So we know that the phrenic nerve is derived from C3 to C5. It innervates the diaphragm. Usually, what's happened is that pain due to diaphragmatic and mediastinal pleura is often referred C3, C5, and this innervates the diaphragm. Very high yield for you to remember that it's kind of like innervating the diaphragm. All right, next question. 14th question. You guys are doing really good. Really proud of you. On physical examination, decreased sensation over the inner thigh and mons pubis, but sensation is intact with the gluteal region. Okay, we talked about this. What type of nerve is affecting?
Ilioinguinal.
Okay. Why isn't it pudendal? Anybody?
Because
One
pudendal
another
doesn't supply the lateral thigh, inner thigh muscle. It's just on the.
So why isn't it pudendal? The reason that it's not pudendal because it can occur due to operative vaginal deliveries because the pudendal nerve courses around the ischial spine. This injury, it usually presents with perineal pain. So we do not see any sort of perineal pain over here. So whenever they put a perineal pain in the clinical vignette, that means they want you to put pudendal as an answer, but they did not do that over here. So the commonly nerves are ilioinguinal and iliohypogastric. They're very at greater risk of injury. Patient with an ilioinguinal nerve injury typically have paresthesia of the upper medial thigh, mons pubis. What if it would have been an iliohypogastric? What features would that have?
Premasteric reflex would be positive for this.
and the suprapubic sensations will be lost in case of iliohypogastric.
Also, there will
damage.
be lesser sensations over the gluteal region. You see this? Sensation is intact over the gluteal region. In iliohypogastric, the sensation is not intact on the gluteal region. All right, you can see this over here. Okay, so they are not intact, and yeah. Okay, next question. So we have a 7-year-old boy ED because after injury to the right side, physical examination, sole and right knee, distal are intact. Everything is intact. X-ray has a pedular fracture. Patient is referred to orthopedics and placed in a leg cylinder cast. On a follow-up, a week after cast placement, paresthesia, numbness, weakness of foot. What's happened?
There is injury to the common peroneal nerve.
All right, so what do you think the answer is?
B.
Everybody else?
Yes. Yes, because of the involvement of common peroneal nerve. And common peroneal nerve commonly injured at the level of fibular head because it is very superficial at that level.
Very good. It's the fibular head. Again, sciatic nerve, same thing. We talked about that. The reason that it's not compartment syndrome, why? Because if they come up with pain out of proportion, whenever they say pain out of proportion, it's very, very painful, and that means you're talking about compartment syndrome, and then it can be probably the answer, but it's not the reason over here. All right, we know that the peroneal nerve injury causes eversion and dorsiflexion. Ped mnemonic, okay. Peroneal causes eversion and dorsiflexion. Very high yield for you to remember. All right, next question we have again. So what's happening is that there's a 67-year-old woman, lung cancer, loss of gag reflex. Okay, when the patient says to and the uvula deviates to the right side. What do you think is the answer over here? Until up over here. Loss of gag reflex.
Hypoglossal?
9th and 10th.
Yes.
Okay. Chest X-ray shows a right lower lobe lung mass, severe osteolytic rib lesion. So she's a patient who has cancer. She has multiple metastases everywhere, and now it is impinging on the cranial nerves as well. What do you think the answer is?
9th, 10th, 11th, all the nerves are involving here. Shoulder droop with the 11th nerve. So it will be the jugular foramen. Because the 9th, 10th, 11th, all nerves pass through this foramina. foramen ovale only the fifth and the hypoglossal 12th. That's not the here. CP angle is the 7th. No, it will be F.
So we all agree it's jugular foramen.
Yes.
Yes. So
Yes.
again,
Yes.
very high yield for you to remember all of this, which I absolutely hate. Unfortunately, they asked this on step one. You have to memorize it. USMLE step one is a very memorization based exam. USMLE step two, thank God, it's not a memorization based exam. It's more about management, clinical vignettes. So I know it's really excruciating for you to remember this, but again, there's no other way. All right. Okay. Then we
Miss
have the second.
Maheen, I have one question. Sorry
Yeah, sure.
to
Yeah, sure.
interrupt. Yeah, actually, like they just give the pictures, or they can give the scenarios? Most people say they just throw the random pictures, like the pictures, and then they ask for the fossas and the nerves.
So they can give you
So
both
hard.
pictures and the scenarios as well. The reason that they give pictures lesser on step one is because the pictures can give us the answer right away, right? So pictures they can give you. They can also give you the vignette. So they can give you both. Try to be familiar with both. Do not rely on the picture. Uh, Also try to go through what they're asking. Like for example, they ask you about, okay, these nerves are getting involved. This is getting involved. All right, and then you kind of summed up and you said that it was jugular foramen, right? So focus on the vignette as well. Again, I told you the nerves, from where they're coming, what are they supplying. It's really, really high yield for you to remember. Okay.
Yeah,
Okay.
thank
All
you.
right. Okay, next question. Second last question for today. So sensation is diminished in the medial upper arm near the axilla. Shoulder range of motion is normal, and the rest of the physical examination is unremarkable. Injury to which of the following nerves is most likely responsible for the patient's symptoms? All right, mastectomy. Very easy answer. What do you think is happening?
Thoracodorsal.
So what do you think is the answer? Thoracodorsal or
Thoracodorsal.
Thoracodorsal.
thoracodorsal? Everybody agrees?
Yes.
So it wasn't thoracodorsal. See, the reason that it wasn't thoracodorsal because they are not asking you about the winging of the scapula. They're not asking about that. You see over here how is it thoracodorsal? So this is a latissimus dorsi. We talked about that. This is the serratus anterior. This is the pectoralis major. This is the minor. In axillary lymph node dissections, the nerves at risk are all of these nerves. All right. So you will have thoracodorsal nerve at injury. You will also have the long thoracic nerve at and also the intercostobrachial nerve at the injury as well. Now the reason that it wasn't thoracodorsal was because what is happening is this. Do we see this over here? Do we see that there is loss of adduction? They did not mention that there is loss of adduction or arm weakness. They did not tell us in the vignette that means that's not happening. And when that's not happening, that's not thoracodorsal. Intercostobrachial. Why is it intercostobrachial? Anybody? Okay, what does intercostobrachial do?
Don't know.
Anybody else? Okay, so intercostobrachial usually involves the sensory dysfunction, all right, in the medial upper arm. Again, not very high yield for you to remember. Even if you're getting it wrong, it's okay. All right. What I want you to remember over here is supracapular nerve, thoracodorsal. These are the very high yield nerves that you need to remember. These are not important. But if you kind of go through that, just remember that intercostobrachial, it innervates the sensory findings of the medial upper arm. And that's it. That's what I want you to remember from over here. Okay. Sensory dysfunction to the skin of the axilla. Just remember, skin of the axilla, intercostobrachial, that's it. All right. And nothing else that you need to remember from these two. Try to remember supracapular, thoracodorsal, very high yield for you to remember. For intercostobrachial, just remember it supplies the axilla, sensory portion of the axilla. Okay? Okay, next question, last question for today. Oh, no, I think it's not a neuro question, but okay. So 34-year-old woman, gravida, blah, 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 PMI is 23, vital signs, physical examination is normal. If fertilization and implantation occur in the cycle, when would the beta HCG would be first be able to detect?
C.
8 days after fertilization.
8 days. C.
Yeah, so it's not kind of
8 days.
associated with the neuro module. It was, I don't know how it came up. But yeah, so with that, we are done for today. If anybody wants to ask anything, they can ask me.
Hello, doctor. I wanted to ask that do the NBME follow the percentage, I mean the range which they have given in the first aid, like the system wise?
Okay, so what percentage did you get?
No, I'm asking about the percentage of syllabus, like they have given the, for example, cardiovascular system, 5 to 9% of range. I mean the questions.
Oh, so you're asking the range of the systems that are coming in the NBM.
Yes, which is given in the first aid. So do they follow this system in actual exam, or it doesn't depend?
No, so I think do not worry about that. Do not worry about the range of the systems. Just go with the like for example, go with the subject wise. For example, go with pathology. Okay, pathology they ask you a lot in step 1. 70 to 80% is pathology. The rest is pharmacology, micro, immuno, biochemistry. These are very high yield for you to remember. So most of them is pathology. So go subject wise. Do not go system wise. Because system wise it's very difficult for you to kind of separate all of it. Okay,
Thank you.
I think it's on NBME website. If you go and they have the all this that how much percentage, like Miss Maheen told you, Dr. Maheen, about the pathology, physio, how much that will come. It's written there.
yeah, but do not worry about what's going to how much things are going to come in your paper, because it's just wastage of time. Okay, if you're trying to figure out, okay, how many questions will I get from cardiology in my paper, then that's just wasting of your time. You could have focused that onto solving more questions and improving your percentage, right? So do not worry about what percentage of questions from what system will come in your paper. Try to focus it subject wise. If you really want to grab on to the percentage thing, then go and focus the subject wise. Focus on pathology as of now.
Okay, thank you, ma'am.
All right. Anybody else? Okay, so I think we're done for today. Good luck, guys. Dr. Ahmed will take over from here. And yeah,